from here. Good afternoon. I am Victoria Lancey, and I'm the Rural Education and Communications Manager with Michigan Center for Rural Health, and I would like to welcome everyone to our Macro MIPS and APMs education series. Our topic this month is understanding the requirements for quality category reporting. And just to let you know that this recording will be posted on the MCRH website at www.mcrh.msu.edu. Click on the resources tab across the top and then the QPP drop down. With that, I would like to introduce our speaker from Hall Vendor Killian Heath and Lyman, Brian Bauer. Go ahead and take it away, Brian.
Well, thanks, Victoria, and good afternoon, everyone. I appreciate the opportunity to speak to you about the MIPS and the quality reporting in particular. We're at the end of December now, and hopefully everyone's been collecting data throughout the year, but whether they have or haven't now is kind of crunch time when it comes to quality reporting or comes to reporting period, both for the quality, the promoting interoperability, and the improvement activities category. It's kind of crunch time for all reporting on all those quality or on all those categories. We'll see in a minute the specific deadline for reporting. This year, unlike last year where there was kind of a phase in and lesser reporting requirements, this year the reporting requirements are basically what's required by the statute and the regulations. They're kind of up to full speed, and so we actually have to be reporting data for the full year, January 1 through December 31. But that end of the year data, the ultimate reporting of all the data for the end of the year, if you've already submitted some, or if you're just submitting one report, uploading one file with all the reports in it, all the data measures and reporting, that's got to be in by February 28th. And so, like I said, it's kind of crunch time at this point. Not to ruin your holiday spirit at all. Don't mean to do that, but it's just the end of the year is here, and so we're going to have to really be stepping it up if we haven't been collecting that data. So the objectives, or kind of high-level overview of what we're going to be talking about today, is the quality reporting requirements, or the process for quality reporting. And so, one of the things that's important, if you don't have it, is setting up an EIDM account with CMS. That's basically how all the QPP data is going to get reported. Some of it may get sent in directly if you have a third-party vendor submitting data, like a qualified registry. But for the most part, at least as far as the providers are concerned, this is the portal. This is the way in to submit your data, to review your data, to manage your data, to get feedback from CMS with regards to, all right, based on the data you submitted, here's your quality scores. And so, oh gosh, at this point, we still have some time. So if our quality score is less than the maximum 60 points, are there other quality categories that we can report on that might elevate that score? So the EIDM account is really basically where that all happens. The quality reporting fundamentals, I just wanted to recap some of that. What measures to report. I think in a lot of cases, providers have already chosen those measures and have been collecting the data. In some other cases, providers are still, based on the year's experience, trying to figure out what categories they may choose, because in order to get full potential points for any particular quality measure that's reported, you have to have a completeness factor of 60%, but maybe the one that the at least with some small practices, you're kind of wrestling with on some of the quality measures. You have to have a minimum of 20 measures and for that, or 20 cases for that particular measure. So in some cases, some small practices, are taking a look at their cases and the quality measures now just to see which ones make sense, making sure they have the minimum 20 cases for each of those measures. Submission mechanisms, and then tips for maximizing the points. So, as we talked about throughout the year, we have 4 categories and the various weightings. For this year, 50% of the performance score is going to be based on your quality scores. So obviously, choosing the right measures, making sure you have the requisite completeness and the minimum number of cases, and obviously very high performance on each of those measures is going to make a big difference on your overall score. So quality is very, very, very important. And obviously, as the slide indicates, you add each of the categories, come up with a maximum of 100 points, and your final performance score, if it's above the threshold, then there's a positive adjustment. If it's right at the threshold, it's neutral, no increase, no decrease. And obviously, if it's below the performance threshold, then there's a negative adjustment. So the quality category overview. Last year, the quality category was 60%. It's down to 50%. It's still, I think, the most important category, of course, because it's the largest one. Where the extra 10% was, well, that was the result of additional weighting going to the cost category. But the cost category is something beyond our control. It's measured by CMS, purely based on claims data. We have very little ability to impact that, at least directly. And so, again, we need to be focused on the quality. Measures that do not meet the 60% completeness are only going to get a maximum of 1 point. So if you report a measure but less than 60%, so you don't meet the required completion requirement, you're only going to get a maximum of 1 point. Now, that's a little different for small practices. Small practices, i.e. those of 15 or less, are going to continue to receive a minimum of 3 points. So if you report on a quality category, a quality measure, and if you report on it at all, even if you don't meet the completeness, the 60% completeness requirement, you're still going to get a minimum of 3 points. So quality reporting fundamentals. Need to report on at least 6 measures. You can report on as many measures as you like. There's approximately 270 quality measures that you can report on. So obviously there is a lot of options out there for your practice. Again, we'll talk again a little bit more about the completeness and the minimum number of cases requirements, but there are a lot of options. You have to report on at least 6. Need to report on at least 1 outcome measure. If outcome measure is not available, there may be a situation where you have less than 20 cases for that particular measure. So you have less than 20 cases for any outcome measure. Well, then you wouldn't have it available to you. So then you need to select a high priority measure, and the high priority measures are defined as, of course, the outcome measures, appropriate use measure, a patient experience measure, a patient safety measure, efficiency measure, or a care coordination measure. So at least 6 overall measures. One of them needs to be an outcome. If an outcome is not available, then it has to be at least another category of high priority measure. So your performance in a category is only considered when you meet the data completeness requirement. That's what I mentioned a moment ago. You have to report a measure at least 60% of the time it applied throughout the year, the data completeness requirement. And so basically what you're looking at is the situation, and I'll just use it as an example, the tobacco use and cessation quality measure. If you have patients that come through that would otherwise qualify for that measure and you report on it, and at least 60% of the time you need to have actually gone through and asked the required questions. And the screening questions, have you used if you use tobacco, and that's not limited to smoking, it would be obviously smoking, but any other form of tobacco use as well, such as chewing. You have to ask the screening question and then provide the cessation or the guidance or the counseling with regards to quitting tobacco use. That has to be done at least 60% of the time when the patients come through. So you have this situation where you have the numerator being the actual number of times that a qualified patient came through. They were asked a survey question about tobacco use and then provided guidance on cessation if they indicated that they did use tobacco. And then the denominator is the total number of times a qualifying patient came through. So at least 60% of the time that measure could apply throughout the year, it has to have been used. If not, then that measure will not qualify. So if in essence, in your practice, when a qualifying patient came through and they were asked maybe an annual wellness visit and only 50% of the patients were asked about tobacco use, then you're not going to be able to report on the measure. Or if you do report on the measure, you're going to receive only that minimum of 1 point. If you are a practice of 16 or more, or a minimum of 3 points if you're a practice of 15 or less. So that data completeness requirement is important. With larger practices, I think it's almost essential that you be collecting that data routinely as you go through years. Smaller practices, I think you have a little bit greater flexibility, but obviously if there hasn't been a lot of collection throughout the year, it's going to be crunch time now. And you obviously, when you're doing the data collection for the year, you're going to have to meet that 60% requirement, completeness requirement. So if you haven't been collecting data throughout the year, you are going to have to go back and collect the data for that particular quality measure for the full 12 months, January 1 through December 31 of 2018. And then you need to meet the case volume requirement. CMS requires that at least 20 patients are included in the measure. So you need to meet the 60% requirement and the 20 patient or 20 cases requirement. So even if you report on 100% for completeness purposes, if you only have 18 patients for that particular measure or case, you're not going to get any credit for that. There just isn't. CMS believes that 20 patients is the minimum threshold for accuracy for measuring performance on a specific measure. All right, so some of the differences in the quality measure classifications. Process measures show what clinicians can do to improve or maintain the health of healthy people or those diagnosed with a given condition or disease. The outcome measures show how healthcare service or intervention affects the patient's health status. Obviously, outcomes they're impacted by factors. They're impacted by factors that sometimes are beyond the physician's control. And so even though things like surgical mortality rates or hospital-acquired infections certainly are very important outcome measures, sometimes they are impacted by things beyond the provider's control, and as a consequence, intermediate outcome measures meet the requirement of outcome measures or meet the criteria of outcome measures. High priority measures, as we mentioned a minute ago, are outcome, appropriate use, patient experience, patient safety, efficiency measures, and care coordination. So what quality measures should you report? Well, first and foremost, I think you need to choose quality measures that work for you in your practice. And so what does that mean? Well, I think as a threshold, it has to be quality measures that you know you're going to have the minimum case, the required minimum number of patients or cases. So it's got to be at least 20. I think it should be a measure that you know you're going to be able to demonstrate the 60% completeness requirement. And those are kind of the threshold. And then once you get to those quality measures, all the quality measures that would meet those two requirements, then I think you focus on the quality measures that you know that you're performing well on. You know, if again, to just focus on the tobacco use and cessation counseling, that measure, if you know that every time a patient that otherwise would qualify, every time a wellness visit comes in, you're asking them about tobacco use, you're documenting that you asked them about tobacco use, you're documenting their answer, and you're also documenting that you provided the cessation guidance. You know that you can perform well. You know it's above the 60% completion. You know that there's more than 20 patients in that category. You know, go ahead and use those. Now, there's a lot of focus, and part of this is just is a resource thing, given the individual practices. But there's always a lot of focus on, well, I know I have to have a minimum 6 quality measures. At least one's got to be an outcome or other high priority measure. But there's nothing to say that you can't report on 8, 10, 12, 16. Again, I understand it's a resource issue. A lot of small practices have limited resources. It's particularly tough on a small practice if that data hasn't been collected throughout the year, and now it's going to be crunch time, and we're going to be collecting it over the next 2 months, January and February of 19. But I think the more categories you can completely submit, the better off you are. I mean, you get the highest. CMS will always take the highest score. So if you report on 10 measures, they will pick the 6 quality measures that give you the highest score. They'll factor in, obviously, any performance bonus scores that you qualify as well. And so it's especially with the variation you may have from year to year in how your practice does on a particular quality measure. If you can report on the more than the minimum 6, so much the better. And then I think once you've found a measure that works for you, you need to look at the appropriate measure specifications that align with it. What's the benchmark? What's the performance? Where do I need to score in order to maximize the points? So it is important to look at that, and CMS does provide tools to do that. In particular, the CMS QPP Quality Measure Lookup tool. It's a very useful tool, and if you haven't had a chance to use that tool or explore it, play around with it a little bit, I encourage you to do so because I think it is very, very useful. If you report through a qualified clinical data registry, you don't generally get to choose the quality measures that are going to be submitted on your behalf. Generally, the QCDR has its own quality measures developed and approved. So it's typically 15 measures that the data registry is collecting. The qualified clinical data registry is collecting, and then they will put together and either submit, depending on the vendor, either submit that directly to CMS on your behalf or provide you with JSON file probably that you would upload to CMS. But the thing that's important here is you're not selecting the quality measures. Those have already been selected, and the QCDR vendor is actually collecting that data, compiling it, aggregating it, and then providing it either to CMS or to you to provide to CMS. And of course, if you're a MIPS APM, that is, if you are a Track 1 Medicare Shared Savings Program ACO, if you're participating in a MSSP ACO, then the quality data is being collected on your behalf by the ACO, and the ACO is reporting that data, and all the providers, all the NPIs and PIN combinations that are participants in the ACO are that quality data is being reported by the ACO on your behalf. So the quality data, you will have no need to report quality data if you as a provider are participating as either a participant or a provider of a participant in a Medicare Shared Savings Program ACO. All right, well, you know, I always hate to say this in December, gosh, you should have started collecting your data in January. Yeah, it's always good, and certainly heading into 19, that would be my recommendation. But you know, if things happen, if life happens, and you weren't collecting all the data, well, you know, obviously there's going to be a catch-up period here now. But because you still need to meet the data completeness requirements, and obviously the minimum number of cases, but the data completeness requirement. So you know, if you have 100 cases each month, to hit that 60%, you're going to have at least 7 months worth of data. Obviously, the better course is to have 12 months worth of data, but you know, you are where you are right now, and you need to make sure that you hit that data completeness requirement. So I would recommend that you pick the 6, at a minimum, you pick the 6 quality measures that you can most easily hit the data completion and the minimum case requirements. As I said, you need to have 12 months worth of quality data. If you're participating in a MIPS APM, you should work with your APM entity on timeliness and required activities for the performance period. But generally speaking, your ACO, again, a MIPS APM would typically be a Medicare Shared Savings Program Track 1 ACO. If that's the case, then more than likely they've already been reporting that data or are in the process of reporting that data. But it's always good just to make sure that that's getting reported, just to verify that there isn't some gap for whatever reason. And as far as CMS knows, they didn't receive any data from the ACO. They didn't receive any data from you because you believe the ACO was reporting, and then they end up not getting any data at all, which of course results in a score of 0. So it is always good. I'm 90% sure if you're in an MSSP ACO, they've been reporting the data as they're going and will continue to report it pursuant to the MSSP program, but it never hurts to verify that that is actually happening. All right, so there's 6 ways that participants can submit data. Obviously, I'm talking about those MIPS providers that are not in an MSSP ACO or any other form of ACO, because that data is already getting reported through the ACO. So this is for providers that are not in an ACO. There are 6 ways to generally submit the data. One is through an electronic health record. Either your EHR vendor or other vendor that may be assisting you can pull that data together. You can pull it together yourself and report it. Qualified clinical data registry, qualified registry, CMS Web Interface. I mean, this program is focused more on small and rural physician practices, and so this probably will not apply in most cases, because to use the CMS Web Interface, the group, it's limited to groups, registered groups, and virtual groups that have 25 or more providers. So in most cases, that will not be the audience of this presentation. Obviously, there's always exceptions, but generally speaking, it's probably not going to apply in our case. Consumer assessment of health providers and systems, CHAPS surveys for MIPS. Again, that's limited to groups, registered groups, and virtual groups only. There is no size requirement there, so if you have a small group of 5, still could use this option. And then claims. Claims data is another way to submit it. That is limited to providers that are reporting as individuals and not through groups. Okay, so the Qualified Clinical Data Registry, or QCDR, can be used by individual MIPS eligible clinicians, groups, and virtual groups. Got to be approved by CMS. I think CMS has approved, I think it's 18 QCDRs for this year. They collect medical and/or clinical data to track patients and disease. Each QCDR usually gives customized instructions about how to submit the data, because obviously you either need to submit it or you need to access through your EHR. So again, that's probably something that's been ongoing for you as opposed to where you are now. Although depending on the QCDR, they may well be able to step in and help you at this point as well, even though it's kind of late in the year. For MIPS eligible clinicians who choose this option, have to participate with QCDR that is CMS approved, and again, I think there's 18 for this year. Qualified registry, as opposed to a qualified clinical data registry, can be used by individual MIPS eligible clinicians or by groups and virtual groups. The qualified registry collects the data and submits it to CMS on behalf of the clinicians, whether those are individual reporting or groups or virtual groups. And for MIPS eligible clinicians who choose this option, again, the qualified registry has to be approved by CMS, and CMS has published a list of those qualified registries. Electronic health records. Again, this option is open to individual clinicians, groups, and virtual groups. Clinicians can submit the data to CMS they've collected through their own EHR, or you can do this working with a qualified health IT vendor who will submit the data for you, or perhaps provide you with a file for you to upload to CMS. Claims data submissions. As I mentioned, this is only available to individual clinicians, not to groups or virtual groups. Clinicians pick the measures and report through their routine billing process. As a part of that routine billing process, certain billing codes need to be added just to make sure that CMS is collecting the data. For the 2018 performance period, claims should be processed through the quality performance category via your MAC, including claims adjustments, reopenings, and appeals by March 2nd, 2019. So should be working with your MAC for any specific submission instructions or timelines for the QPP program. Generally speaking, I've found the MACs to be really helpful on this. I think they're really committed to working with physicians and groups. With physicians and individual physicians. I think that they've been very helpful in my experience. All right, CMS Web Interface. I do want to touch on this, even though just because it may apply to some groups listening in. Can only be used by groups and virtual groups with 25 or more clinicians. It's a secure internet-based application that pre-registered groups and virtual groups can use. A sample of beneficiaries are identified for reporting, and CMS partially pre-populates the CMS Web Interface with claims data from the group's Medicare Part A and Part B beneficiaries who've been assigned to the group. The group then adds the rest of the clinical data for the pre-populated Medicare patients. Reporting is via the web interface, and it requires that you submit the data for all measures in the application. So whatever the required measures are, you have to cover them all and not just choose or select some of them. In the event that there isn't sufficient sample size, CMS will recommend selecting a different data submission option. So this is where it all starts, qpp.cms.gov. You see that more and more on the CMS websites, more and more in the CMS communications, their updates. It's really where you need to go. So this is the site, qpp.cms.gov. It's where you go to submit, verify, and manage your MIPS data. And that's for the quality category, the improvement activity category, and the promoting interoperability category. Just a note, CMS, you may or may not be aware, and actually if you're on the CMS websites looking at some of their older guidance, you will see them refer to advancing care information. That was the name of the category. I think of it as an EHR category. That was the name of the category at the beginning of QPP and MIPS. They've changed the name to Promoting Interoperability. It's probably a better name, but it gets a little confusing because if you're looking at some of their guidance, you don't see Promoting Interoperability. You're seeing Advancing Care Information. So just a note, they're the same thing. The requirements didn't change with the name. It's just the name change. So if you're looking at guidance with regarding to advancing care information, it is mostly applicable to promoting interoperability. I say mostly only because that the language, the advancing care information, was usually in guidance for 2017 reporting. The 2017 reporting was a little different than the 2018 reporting, and so there is some slight differences. It's not because of the change in the name, it's because the change in the year. Enterprise Identity Management System is the system that providers use to apply and receive a single user ID that those providers then use to access various CMS applications. Not necessarily limited, sorry about that, it's not necessarily limited to QPP or MIPS. It is what you do, or it is what you use to submit, verify, manage, access your reporting under QPP and MIPS. But there's other CMS applications that use the same EIDM system. So first thing you need to do is you need to have an EIDM account. And you may already have one, especially if you used EIDM to report PQRS data previously. But first thing you do with reporting or uploading, say, you're collecting your own data on quality from your EHR. So to upload that report, first thing you do is you go to qpp.cms.gov. Up in the upper right, there's a sign in button. Click on the button to create account. It'll allow you to create account, or as I said, if you previously used the EIDM program or system, then your EIDM account should have already migrated for use by you in the QPP reporting. You can still use your existing EIDM account so long as your password is still valid, but you should be able to do that. If you do not have an existing EIDM account, you'll need to create one. Basically, you go through the process. I mean, obviously, it goes through the identification process for identifying your provider numbers and your tax ID numbers, NPIs, and it allows you to identify basically what I think of as two categories of users. There's the security officers, and that's the term that CMS uses. The security officers basically have full access to your EIDM account, to the provider's EIDM account. So they're able to do access and basically do anything. One of their important functions is to authenticate or authorize certain other users to perform certain other tasks in that EIDM account. So you may have some individuals in your group or in your practice that are going to import or input certain data. You're going to be able to input the data and have some ability to manage the data, but you don't want them to have full access. The security officer identifies who that individual is and identifies specifically what they're authorized to do within the EIDM account. So now, it's also important to know you can have more than one security officer. The security officer it doesn't have to be just one individual. With larger groups, larger practices, I would expect you to have more than one security officer, just to make sure that as you have individuals that may be working on that data, inputting that data, and in that EIDM account, you may well need have access to a security officer 24/7 if it's a large enough practice, just to make sure that you have a security officer always available to make sure you're able to function in that EIDM account. On the flip side, with a solo practice or small practice, I'm guessing you may only have one security officer, or you may choose to have each of the providers in a small practice. Let's say you have a 5-physician primary care practice. You may choose to have each of the physicians be security officers, and other individuals in the practice that may be involved in working with the data and the reporting have less access. I've seen that as well. So once the security officer is identified, then the security officer is able to see and manage everything, and again, identify and authenticate and authorize others to work in the EIDM account. So once the logger uses, once you've set up your EIDM account, or you've logged in because you previously had an EIDM account, you're going to see a dashboard that's appropriate for the user's approved EIDM role. If you're a security officer, you're going to have full access, and the dashboard that pops up when you log in will give you that full access. If it's another individual that has less than full access, their dashboard will be different. But for the purposes of our discussion, I'm going to focus on what a security officer would see when accessing the EIDM account. So the security officer can begin or manage a report for that provider. So you log in, you click on the sign in, you log in, you'll get your dashboard. If you have not otherwise started submitting data, you will get a screen that will show you basically three categories for reporting. The quality category, the improvement activities category, and promoting interoperability category. You'll have each of those categories pop up. You click on it, and once you do that, based on the security officer's or authorization, some cases you may have a security officer serving and able to report for more than one tax ID number. Typically in small practices, you're just going to may have more than one security officer, but it's only going to be for the one tax ID number for that practice. So you click on that, and then it will give you a menu that will allow you to either begin submitting quality data for an individual or a group, depending on how that tax ID number chooses to report. So first you select the category, and for our case, we're just going to focus on the quality category. So you select the quality category. As I mentioned, if no quality data had yet been submitted, a menu permitting you to import a file you'll click on the screen that says quality. The next screen that'll come up will be a screen that'll permit you to upload the quality data pursuant to a quality data file. There actually is, at this point, the opportunity for having either, I'm sorry, I jumped ahead of myself a little bit. The screen that will come up will be, it'll allow you to report as either the provider, or if you have another vendor, a registry, or somebody else providing, then it'll allow them to access and provide that. So I apologize, got a little ahead of myself. So you sign in. As soon as you sign in, if you haven't reported quality data, you will get a screen that shows you buttons buttons for the three different categories for reporting: quality, promoting interoperability, and improvement activities. If you select the quality one, obviously it'll work the same for each of the three categories, but for our purposes, you select the quality one, you click on the quality one, then it gives you the opportunity to report your data yourself, or allowing a third-party vendor, again, such as an IT, EHR vendor, or a registry vendor, to report that data. Oftentimes, if you have a registry or other vendor, they take over at that point and provide the data to CMS. So what we're going to do is focus, for the purposes of our discussion, on as if the provider was reporting the data. So you would click on the button that talks about provider reporting the data. Once you click on that button, then you will see a screen that will allow you to upload files. So depending on the file, it could be a QPP file or a QRDA3 file. It's probably most typically a QRDA3 file because that's the format that's used by EHRs. So assuming that you've used in your EHR, you've created a file, a QRDA3 file, that has the quality measures and the quality data in that file, then you typically just click and drag from your computer the QRDA3 file and drop it in and upload it in CMS via this link. And by completing the upload, you have submitted your data to CMS. Now, if you've been doing this all along through the year, obviously you're updating the data every time you go in, or you may be updating the data you previously inputted or imported and uploaded, and then maybe adding new measures and new data. So if you reported on 3 measures through the first 6 months of the year, and then in the third quarter you added another 4 measures, and then in the last quarter, you're updating the previous and adding some additional measures. You know, that's how it gets managed through this. It's typically kind of a click and drag from that QRDA3 file from your EHR. So once the data has been uploaded and that upload is complete, the data has been submitted to CMS. Again, you know, it may or may not be your complete data. I would guess that it would not be at this point your complete data, because you are required to report on the data for the full year. And although we're very, very close to December 31st, chances are data from the fourth quarter of 2018 is still in the process of being collected and submitted. So, you know, you upload the data. Once the upload's complete, then you're able to close out and go and review the status of the data that you have submitted. So this is a process. You can just, you know, you can submit it. If you have on the file, on your QRDA3 file, if you have all your quality measures for the entire year and all of that's ready to go, January 20th, you can submit that file one time for all the measures, and it doesn't even have to be limited just to quality. That same file could also have promoting interoperability data and improvement activity data. You could have all that data on one file, upload it. I think it's probably a little bit more common. Well, maybe I shouldn't put it that way. It also happens that you can upload the data as you're going along through the year. So you have the flexibility to go either way. The thing that's very useful here, I think, for this EIDM program for the QPP is that once you've uploaded that data, you close out of that upload screen, and then you get a new dashboard. And the dashboard actually allows you to see the data that you've uploaded, and it allows you to see what the score is, what the performance is. So you're able to see the data and the consequences of the data. So once the upload's complete, close out of the upload screen, and after the submission, the previous screen, the one that you had the first time that gave you the option to initiate data download, you're going to see a different dashboard. And this will indicate a number of things. One, the screen indicates what submission methods have been used, because again, you could use the same individual or group may submit certain quality measures via different methods. And so CMS tracks each of those. They'll compare them. They'll give you scores on how you did on this particular reporting method or submission method as opposed to the other. And obviously the total score will be the best possible score, taking into account all the quality measures and all the submission methods. So the scores for the quality submission or submissions, this screen also includes a link to the full instructions for the use. Again, I'm not as involved on a daily basis in submitting this data. I get a chance to play around with it a little bit, but the instructions I thought were very useful, very helpful, and very user-friendly. This screen will also show the performance for each measure. So if you've reported on a total of, let's just say, 10 quality measures, it will show you, it will do a number of things. First of all, it will pick out of those 10, the 6 that give you the highest quality score. And then for those 6 first, it will show you for each of those quality measures, it will show you how you did compared to what the benchmark is, how you did compared to the benchmark, and what your score is for that quality measure. Also indicate if there's any bonus, like an end-to-end bonus that might add points as well. the score will show you your overall performance for the quality category. So in addition to showing your performance on each of the individual quality measures, it will show you your performance on the total quality category. And again, if the data is submitted by more than one method, it'll show the performance score for each reporting method. System, as I said, selects the top 6 measures that'll give you the highest score, but CMS will score all measures. So if you reported on 10, it'll pick the 6 to give you the highest score. It will show you the performance, again, your performance on each of those individual quality measures. But it will also give you your performance on the quality measures that are in the 4 that didn't make the top 6, just so that CMS provides you feedback on all the quality measures. That's useful, I think, and clearly CMS believes so, in encouraging better performance in those quality measures in the future, even though they didn't apply to your quality score in this case. And again, CMS will use the measures and reporting methods that result in the highest score. I do want to point this out because I think CMS has really upped their game as far as providing technical assistance. In addition, obviously, to these webinars, CMS has a number of other technical assistance opportunities. If you go to the qpp.cms.gov, obviously you need to sign in to the EIDM system. But there is what I thought was a very helpful video that explains the use of the QPP EIDM method, not just for the quality category, but also promoting interoperability and improvement activity categories as well. Claim submission mechanism applies to individual clinicians. For claims, excuse me, in the 2018 performance period must be submitted by February 28th, 2019. So if you're using the claim submission mechanism, those claims that you intend to use for capturing the quality data need to be submitted by February 28th, 2019. For the QCDRs, the qualified registries, the EHRs, CMS Web Interface, the data submission period begins or ends no later than March 31, 2019. Now, I've also included some language, I think some of this just says what we've talked about earlier in a slightly different way. Some of it's just refresher. I think it's important to touch on. Got to select 6 of the 270, actually slightly more than 270 available quality measures. Got to be for a full calendar year. Clinicians receive 1 to 10 points on quality measures based on their volume, data completeness, and performance against the benchmark. Obviously, if you don't reach the data completeness and you're a small rural, you're going to get 3 points. If you're any other provider or group that's other than the small rural, you're going to get a maximum of 1 point. And then if you get the data completeness, your performance above that minimum depends on how you perform against the benchmark. I mean, if you exceed the benchmark, you hit the sufficient score, then you get the full 10 points. Some cases we'll talk about here in a minute, there is a performance bonus as well. Failure to submit performance data for a measure results in 0 points, which is the worst possible case. Yep, as long as the denominator for a measure is greater than 0, you'll receive at least 1 point. To score above 1 point, clinician must meet the minimum volume, 20 or more patients, and the data completion, as we talked about, 60%. The failure to submit a performance category for any of the required 6 measures will result in 0 points for that measure. if the measure can be reliably scored against the benchmark, and this gets more to this really gets and explains the basis or the reason behind CMS's use for the completeness and the minimum case or the minimum number of measures. To have a reliable score to measure against the benchmark, you have to meet that 20 or more cases for most measures. In the case of readmissions, it's actually got to be more than 200. If you have insufficient volume, you get a max of 1 point. So again, you want to pick measures that you're going to have more than 20 cases. Data completeness, again, got to be reliably, in order to be reliably scored against the benchmark, you have to have 60% or more. For measures that don't meet that, receive a maximum of 3 points, regardless of performance. So if you have less than 60% completeness, but you score, you just blow it knock it out of the park, and you hit the 99th percentile, you're still going to max out at 3% or 3 points. I'm sorry, unless you have meet the completeness requirement. There are additional bonus points that can be earned, a submission of additional measures, 1 bonus point for each additional high priority measure, and 2 bonus points for each additional outcome or patient experience measure. End-to-end reporting, 1 bonus point per measure for reporting quality data directly reported from your EHR to a quality registry, QCDR, or via the web interface. Bonus points are added to your and your group's virtual group's quality performance category achievement point. Bonus points are capped at 20% of the overall quality score. So, you know, you can make up some deficiencies based on the bonus scores, but they're capped out at 20% of the overall score. All right, I'm just sensitive to time here. There also is a quality performance improvement. So starting with the 2018 performance period, you can earn up to 10 percentage points based on your rate of improvement in a particular quality performance category from the year before. I mean, obviously, one of the important things here is it has to be the same quality category or quality measure you reported on previously. So if you improve your score, you can receive bonus points, even if you're below the benchmark and otherwise wouldn't receive any points or fewer points based on your overall performance for that year. If your performance from 2018 to 2017 is sufficiently better, you may actually receive additional points there and more points you might otherwise have received. Key takeaways, it's worth 50%. Again, this is kind of just recapping what we've talked about before. There's over 270 measures to choose from. Must report sufficient data on a minimum of 6 quality measures. Each measure earns you 3 to 10 points as long as the benchmarks have been established and there's a minimum and you've met the minimum case requirement. I think it probably goes without saying, be sure to choose quality measures that ensure that just when you're choosing quality measures, ensure they're ones that reflect your best performance. Look for bonus point measures, report measures that meet the case requirements, case minimum requirements. Choose your quality reporting vendor and understand how they will support you. If you're going to use a quality reporting vendor, you need to understand how they're going to support, what type of support activities they're going to provide you in meeting your reporting requirements. So because this session has been recorded, we don't have the opportunity to take questions, but as always, you can feel free to reach out to myself or Lisa with any questions you have. We're very, very happy to help. And we look forward. Hopefully you've had a great holiday, and we look forward to our conversations coming up in January, February, and March. So with that, I'll turn it back to you, Victoria.
Thanks, Brian, and thank you for giving us a presentation today. And like Brian said, that if you have any questions, please feel free to contact him, or you can contact our office directly, and we can put you in contact with Brian as well, or Lisa. With that, we'll go ahead and sign off for today. Thank you.
Thank you.